Good afternoon, everyone, and welcome to today's seminars on social care policy research from the NIHR Policy Research Unit. I'm José Luis Fernández. I'm director of the Adult Social Care Policy Research Unit, ASCRU, which has been organizing these couple of dates. Just a couple of things to say that this is the second round of seminars that we organize. The first one was, I think, a great success, and there was a significant appetite to repeat it. And we are going to actually have further dates, probably around June. We haven't been able to fit in all the potential work that could be presented this time around. So there will be further opportunities to present as well as to listen. So keep in touch. We have tried to balance the sources of the presentations, because it's not just obviously Adult Social Care Policy Research Unit doing adult social care policy research across the units, and there's quite a few units doing some very good and important work. And so you will see that there is a range of units represented in these 2 days, and there'll be further units represented in June. Today we've got 3 sessions in effect, although the first 2 sessions are joined and start with this one. So we're now going to have two research papers, and then we will have a session on the role of being a public advisor in the context of policy research on social care, which I think is going to be very interesting. And that session will be chaired by Margaret Ogden. And then after a break, Jill Manthorpe will take over the chairing of the afternoon session, where we have another three research papers. I'm not going to say anything further. I think the best thing is to just give way to the researchers to tell us about their very interesting findings. So the first presentation is from Gemma Spiers, who's from Newcastle University. She's part of the Older People and Frailty Policy Research Unit. And she's going to talk to us about factors associated with unmet need for support to maintain independence in later life, a mixed method systematic review. Gemma is going to talk about 20 minutes, and then hopefully we will have 10 minutes for discussion. So if you could hold on your questions until then, that'd be great. If you want to note them on the chat, that's absolutely fine. That might actually help later on. But Gemma, over to you.
Thank you. I'm just trying to share my screen, but unfortunately I can't actually see my slides on the share screen option. Daniel, would you be able to share on my behalf? And then I can just ask you to flip the slides as and when. Thank you. First technical hurdle, 2 minutes in.
Yes, absolutely. Daniel, are you able to share the screen? Apologies for that. We wanted to have, get rid of all these technical glitches at the very end, at the very beginning, just to have ensure a very smooth rest of the sessions.
You know, we're going to miss all this when we start going back to face-to-face.
Indeed. There you go.
Thank you. Thanks, Daniel. So it's really nice to be able to talk about this work now that we've completed the project. This work was undertaken in the Older People and Frailty Policy Research Unit, and this work looked at factors associated with unmet need for support to maintain independence in later life. And I'm speaking today on behalf of the project team. Next slide, please, Daniel. So the project team included colleagues across Newcastle and Manchester. Next slide, please. Thank you. So we know that there are some older people who need help with day-to-day activities, but they don't always get the support that they need with these activities. And we describe this as an unmet need for support. And although the estimates of the prevalence of unmet need do vary among older people, I can just see a note saying FYI, we can see presenter's view, but I don't know if that's important. So although the estimates of the prevalence of unmet need do vary among older people, nonetheless, this is still an issue. So this presents questions about, oh, it's disappeared from my screen. I'll just keep talking. We can get back to the slides eventually. So it presents questions about who has unmet needs, who could benefit from support but isn't getting it, and the characteristics and the circumstances that are linked to this unmet need. And as we'll soon see, this is quite a large literature, but it's also a complex literature. And it's complex because there are different ways of identifying populations with a need for support, and there are different ways to determine whether that need for support is met or unmet. And there are different approaches to classifying what is support, whether it's paid, unpaid, or both. And because this evidence is big and it's complex, it is quite difficult to make sense of, but getting some clarity about who has unmet needs is really important to drive forward efforts to ensure that that access to care is equitable for all older people who do need support to stay independent in their home and communities. Next slide, please. So we undertook this systematic review to get a bit of clarity on this evidence, and ultimately we wanted to know what factors were associated with an unmet need for support to maintain independence in later life. Next slide, please. Oh, can you just press the down? Thanks. So I'm not going to detail all of the methods, but I'll just summarize a few important points. So on the left of the slide, you'll see the search sources. So we searched bibliographic databases, reference lists attached to aging data sets, sources of grey literature, and references of included studies. Press down for me, Daniel. Thanks. On the right of the slide, we've got the parameters of the review. So we were interested in populations aged 15 over living in the community and in assisted housing. And because we were interested in support to maintain independence, we interpreted that as independence in the community. And so we therefore excluded care home populations. We were interested in any factor that had been explored in relation to unmet need, and we operationalised the outcome unmet need for support to maintain independence in terms of functional independence. This was activities of daily living, instrumental activities of daily living, mobility, or a reported need for social care. And we also used any measure of unmet need. That means absolute unmet need measures, relative unmet need measures, or combined unmet need measures. In terms of the study design, we included observational studies that quantified the association between a factor and the outcome unmet need. And we also wanted to include qualitative data that explored factors implicated in unmet need. And for this, we chose to look at systematic reviews of qualitative data rather than primary studies. And the reason for this is because when we did our initial scoping of the literature, we found that we could identify a good chunk of evidence about factors implicated in the experience of unmet need from recently published systematic reviews. So in the interests of efficiency, we chose to look at systematic reviews of qualitative data alongside the primary quantitative studies. We looked at studies in the English language using data from OECD high-income countries, and we didn't impose any publication date limits. Next. And we just used standard systematic review methods for screening, extraction, and quality assessment. Next slide, please, Daniel. So this slide just summarises our approach to synthesising the data. So where factors were reported in 2 or more studies with comparable analyses and roughly comparable measures and confidence intervals, we visualised this data on a forest plot, and this was just to help aid our interpretation of the data. Where factors were reported in a single study or in 2 or more studies but without a comparable analysis, measures or confidence intervals, we summarise that data in a table. And similarly, for the factors reported in qualitative systematic reviews, we summarised those findings in a data summary table. Next. And this together, these fed into and supported a narrative synthesis of the findings. Next slide, please, Daniel. And if you could just press down again for me, Daniel, thanks. So this slide is a condensed and simplified version of our Prisma flow charts. So for the quantitative evidence, after deduplication, we found almost 10,000 records, and of those we included 43 observational studies. And for the qualitative systematic reviews, we found just over 2,000 records, and of those we included 10 systematic reviews. Next, Daniel. So these numbers at the bottom, these are the numbers of studies that we included in the systematic review. Next slide, please, Daniel. So we identified evidence about 7 groups of factors, and the majority of evidence described demographic factors, socioeconomic factors, and health and disability factors. We found some, but comparably less evidence about factors relating to health service use, care configurations, unpaid carer characteristics, and area level measures. In total, we found evidence about 116 factors that had been explored in relation to an unmet need for support to maintain independence. And obviously, please don't panic, I'm not going to present findings on each of those today. So what I present next is going to be a little bit selective, and I'll focus mostly on the factors that were reported across multiple studies or in the qualitative systematic reviews. So next slide, please. So starting with the demographic factors, these are a selection of the factors that we identified in the evidence. Next, Daniel. And we found evidence that being male, younger ages, living alone, Black, Hispanic and other ethnicities were linked to unmet need. And the qualitative evidence also confirmed living alone, as well as proximity of friends and family and cultural language barriers as being implicated in unmet need. There was less consistent evidence about the role of marital status and geography in unmet need. Next slide, please. So I'm not going to present all of the plots because we'd be here all day, but I'm just going to present a couple as examples. So this plot shows the estimates for living circumstances. So the referent group is typically living alone or some variation of living alone, except for a couple of studies at the top. And the exposure is living with others or some variation of living with others. So we can see here that there's a trend of evidence that compared to those living alone, those living with other people have a lower odds of having an unmet need. This isn't consistent across all studies, and the confidence intervals don't confirm this association across all studies, but the trend of evidence would suggest that there's something there about living alone and unmet need. Just to explain as well, the different colours represent the different types of unmet need measures, and the estimates of the triangle are UK study data. Next slide, please, Daniel. So moving on to socioeconomic factors. These are a selection of the socioeconomic factors that we identified. Next, Daniel. And we found evidence that lower levels of income, lower non-housing wealth, having a mortgage compared to those who owned their home outright, and poor quality housing was linked to unmet need. And the qualitative evidence also identified financial constraints linked to unmet need. The evidence about education, occupation, housing, tenure, and Medicaid insurance in a handful of US studies was inconsistent. Next slide, please, Daniel. So this is the plot for income. The referent categories are all the lower categories of income, and the exposure group are the higher categories of income. The exception here is a study by Lebec and colleagues 2015, and they used a continuous variable. But here we can make an inference that compared to those in the lower income categories, those in the higher income categories had a lower odds of unmet need. Next slide, please. So health and disability factors, again, a selection of some of the main factors that we identified. Next, Daniel. And we found evidence that poor self-rated health, more functional limitations, and a greater severity of depression were linked to unmet need. We also found quite a lot of evidence about individual health conditions and symptoms, which were typically reported in 2 or 3 studies, and in those 2 or 3 studies the evidence about those individual conditions was often contrasting, but in one UK study there was a number of individual conditions that were linked to unmet need, and these included dementia, cancer, osteoarthritis, diabetes, blood pressure. Oh, I've forgotten the other one, constipation, and there was another one but I can't remember it. I can come back to that though. But that was just in one UK study. Next slide, please, Daniel. So these are the factors relating to health service use, care configurations and unpaid carers where we found far less evidence. Next, Daniel. So we found evidence that poor self-rated health for unpaid carers, a longer duration of unpaid caring for multiple activities and dental visits were linked to unmet need. And the qualitative evidence identified the availability and quality of care as being linked to the experience of unmet need. Next slide, please. So I'm going to talk now about some policy considerations from these findings. Next slide, please. Next. So our systematic review identified a profile of people who are likely to have an unmet need for support to maintain independence in later life. And this included men, those at younger ages, those who are living alone, those with on lower incomes or who are experiencing socioeconomic disadvantage, poor self-rated health, greater severity of depression and more functional limitations. And the qualitative evidence also confirmed living alone as being important in having an unmet need, and that evidence also identified financial constraints and the proximity of family and friends. An important caveat here is that these factors were not consistently identified with statistical precision across all studies, but the overall trend of evidence suggested that these are likely to be important. So this might suggest that there's some scope to target support to these groups to ensure equitable access to care. However, I think it's really important that we also think about contextual factors, and that these contextual factors implicated in unmet need must also be addressed. And this includes the availability, quality and adequacy of care and cultural and language barriers, which we identified from the qualitative evidence. So I want to pick out 2 findings in particular just to discuss. Next, Daniel. So the first is the link between younger age categories, younger age groups and unmet need. So this finding may reflect emerging needs that are perhaps not quite serious enough yet for intervention, or which maybe don't meet, are not serious enough or judged to be serious enough to warrant intervention meet eligibility criteria. But given that there's a policy move towards preventative support, this finding suggests that there might be some opportunities here for targeting such preventative support at earlier ages. Unfortunately, because of the way we did the analysis, we couldn't identify which younger age categories exactly were more likely to have an unmet need, but we certainly saw evidence that compared to the oldest populations, the youngest populations were more likely to have an unmet need. Next, Daniel. So the second finding that I just wanted to highlight is the link between socioeconomic disadvantage and unmet need. I think that this is particularly important to consider, given that most people in England at least will be paying towards the costs of their care. So to avoid marginalising these populations who face socioeconomic disadvantage, there is an argument perhaps to increase support for these groups. Next, Daniel. So as a final reflection, before I finish, I just wanted to make a point about the type of unmet need measure. So I haven't gone into detail on this in this presentation just because there wasn't time, but I do just want to highlight that as part of this review, we did in the synthesis, we did try to unpick whether the type of unmet need measure was driving the pattern of findings. So there was 4 types of unmet need measure: absolute, relative and absolute, or a direct question. And we didn't really see any strong evidence that the type of unmet need measure was driving the findings, which was a little bit surprising. The exception was for the link between gender and unmet need, where it looked as if the trend of evidence between being male and having an unmet need was stronger for absolute measures, but this wasn't by any means a clear distinction. So I thought it's just worth highlighting that methodological point. Next slide, Daniel, and the one after. Thanks. So I realised that I've talked through, or tried to get through, quite a lot of findings in a short time frame. But if you'd like to have a more in-depth discussion about any of these findings, please do get in touch with us. The report is currently with our policy liaison, and we're hoping that that will be on the website soon. And we're submitting a paper to a journal this month. But in the meantime, yeah, do get in touch with us if you'd like to talk through any of these findings. We'd be more than happy to chat. Thank you.
Thank you very much, Gemma.
And thanks to Daniel.
Yes, indeed. So thank you very much for that, Gemma. That was not just really, really interesting, but perfect timing as well, which is very much appreciated. So we do have about 10 minutes for discussion. If anyone wants to ask a question. If you could, oh, Valentina, I see, raise your hand.
Hi, Gemma. Thank you so much for that. It was really interesting. One thing that I it's sort of a technical point, but it has implications for your findings, I suppose. I was quite interested how you chose the 50+ age group, because it kind of straddles, you know, it's quite a difficult thing to perhaps choose distinctly by age. So how, in a way, how you did that in practice as well when looking at the papers, because I can imagine that papers would employ different age categories. But then also, you know, that actually then came through in a way in your findings, that it was a younger age group that was, you know, struggling more with unmet need, or having more unmet need. So whether you have sort of any reflections around the choice of that cutoff point and what that might mean for different, because I'm kind of thinking, is it 50 to 60 then that are having more unmet need? And yeah.
That's such an interesting question. Yeah, so the reason it's always the hardest part of reviews, trying to define what you class as older age. Increasingly, we're moving towards the younger age groups, given that those who are more disadvantaged tend to experience age-related loss of independence and ill health at an earlier point in their life course. So we went with that younger age group. In terms of how we operationalize this, it was a very pragmatic approach of populations aged over 50, or where if it's a mixed age study, they had to report separate findings for the 50+ group, or if the majority of the sample was aged over 50, and we did have a handful of those studies. So that's how we operationalized it. In terms of reflections on what this means, I wonder if perhaps this might partly drive the socioeconomic findings, and I should say the findings by age. And perhaps you're right, we might have seen a slightly different pattern if we had just included perhaps 60 and over or 70 over. Perhaps at some point, if there's time, we could do some kind of sensitivity analysis and block out those studies with the younger groups to see what changes. That would be quite interesting. But yeah, really interesting point, and yeah.
Thank you very much. Let's just get 2 questions, and then we can answer them in turn. So Sam first, and then Amritpal.
Excuse me. I don't think I've said any words to any humans today. Just wondering, that was really interesting. I think you just at the end, you touched on the point about types of unmet need, and I was wondering if you could talk a bit more about that, because I guess when I was looking at some of the risk factors that you identified, I was sort of wondering, of these groups of people who have relatively low needs and are not eligible for services, or are they groups of people with high needs, some of which are unmet, or is it some combination? And yeah, I just would like to hear more about that.
Yeah, I'm glad that you asked that, because I did want to include an explanatory point, but I cut it out in the interest of time. So great question. We didn't look at types of unmet need in terms of the level of dependency or how much need. It was just whether or not there was a need. But the types of unmet need measures were absolute measures, which identifies population with a need for support who receive no help whatsoever. Relative measures, which identify a population with a need for support who get support from somewhere but judge that support to be insufficient and report needing more help. Measures that combine those two populations, and then a measure that's a direct question that's quite similar to relative in that it asks, do you perceive yourself to have an unmet need? So you wouldn't know whether or not those groups are getting services. But the argument about the different measures is that an absolute unmet need is perhaps a little bit more conservative. And some argue that an absolute measure will identify those most in need of care because they're not getting any help. And there's an argument that with relative measures, this is very much driven by expectations of care, which we do know can differ across the population. I don't know if that answers your question.
Yeah, it does. Thanks. That's interesting. I think it would be interesting to see whether some groups were more associated with one type or another type. But yes, it does answer the question. Thanks.
Thank you, Sam. Amritpal?
Hi, yes, thank you. I think you partially answered my question in your response just now, but just a comment more generally on the relative measures. I've done a little bit of work on unmet need using ELSA and the Health Survey for England, and something that struck me there within ELSA, trying to estimate a relative using a relative approach to estimate unmet need, the response categories for what degree of help was being received appeared quite broad to me. So individuals could respond, I'm getting help most of the time for this need or some of the time. So it didn't feel very precise. And I was just wondering in general if within the studies that you used for this analysis, if you felt like there may be some more work needed to increase the precision of data to allow estimating of unmet need, at least in a relative context, or if you think that the studies did a good job and were able to identify roughly what proportion of needs were being met.
Yeah, that's really interesting, and you're right that with a relative measure, there's a huge scope for variation, whereas with an absolute measure, it's either yes or no. I couldn't say that this is something that we were paying close attention to when we were selecting our studies according to the criteria. But that's certainly something that I might just go back and have a look at. There were certainly, so when we did the quality assessment, we did look at the questions that were used, and we did highlight a couple of studies that had used combined measures of absolute and relative unmet need, where it wasn't quite clear. Where it wasn't quite clear if they'd used both or not. But that's something I think I don't think I could answer that here. I would need to go back and check that. But it would be quite good to have a chat with you about that at some point if you're available.
Absolutely.
Thank you. That'd be really helpful.
Thank you.
So if it's okay, I'll just sneak one in myself, given that there aren't other people waiting. So just trying to understand the sorts of the evidence that you were extracting about the relativities, how much more likely somebody might be of presenting or noting an unmet need. To what extent is this ceteris paribus or not? So controlling for other things or not? Because I was interested, for example, in the fact that you didn't find very strong effects of unpaid care, and I was wondering whether that's because, in a sense, unpaid care is going to reduce the unmet need because the support that they provide, but also is going to increase with unmet need because because you're more likely to receive support because of your higher needs.
So it's your question about the extent to which these were factored into analyses. Yeah, it was interesting because the studies that weren't about unpaid care didn't really typically factor in sources of support or any type of care, whether paid or unpaid. We only really saw that evidence in the studies that were specifically about care configurations. So that is certainly something to take into account in interpreting the findings, that we don't know to what extent that we're seeing a bias in the findings because they are about unpaid care. But yeah, it's an interesting point. I see what you're saying.
Thank you very much, Gemma. So wonderful. Thank you very much again for a great presentation, really interesting work. Looking forward to seeing that being cleared by the HSC and then published.